Clostridium difficile is an incredibly common disease which is rampant in many healthcare settings, accounting for the majority of hospital-related infections. Clostridium difficile thrives in environments where there's widespread antibiotic use. This is because antibiotic treatments disrupt or completely destroy healthy intestinal microbes, which are essential for combating bacterium such as Clostridium difficile. As you can see on this diagram, bacterial strains such as Bifidobacteria, Escherichia coli, and Lactobacilli are essential for maintaining a healthy gut. Clostridium difficile is one of the harmful bacteria which inhabit the gut. Its proliferation is magnified and accelerated by the absence of those healthy gut bacteria, which serve to both fight Clostridium bacilli as well as take up space so infection does not have as much available room to multiply. The bacterium responsible for causing Clostridium difficile infections is an anaerobic gram-positive bacilli. And the key characteristic of this specific bacterium is Clostridium's ability to form endospores. This ability contributes significantly to the bacterium's virulence because spores are particularly resistant to adverse conditions. Now, this means that spores are able to endure many sanitization methods that would generally immediately eradicate other bacterium, which are not capable of entering a vegetative endospore state. Another key characteristic is Clostridium's metabolic capabilities. Clostridium is an anaerobic organism, which means that it thrives in environments devoid of oxygen. The human gut, then, is an ideal site of germination for the hardy spores, where they can activate and cause widespread damage.
Pseudomembranous colitis was first described in 1893, but Clostridium difficile was not first discovered until 1935, when it was found in the stool of a healthy infant. The two men that made this discovery were Hall and O'Toole. In 1978, George and his colleagues connected C. diff with human disease, and that it was responsible for the majority of cases of antibiotic-associated diarrhea. Our attitude towards C. diff became much more concerned when it was associated with human disease. Since this discovery, C. diff has made its way to be a leading cause of hospital-acquired infection in the US and some other developed countries. This in itself raised awareness of C. diff across the world. According to the CDC, after cases of C. diff increased between 2000 and 2011, the cases have since then plateaued and now have begun to decline. In 2011, there were 76,400 cases reported in the US alone. That year, these cases made up 12.1% of all healthcare-associated infections. At this time, C. diff was still an issue, but a lot of people knew about it because cases were not increasing as much and people were not as concerned. After cases greatly increased between 2000 and 2011, nucleic acid amplification tests began to be used more often. These tests were adjusted and improved greatly and eventually led to a decrease in the number of C. diff cases, with only 365,200 cases reported in 2017 in the US. This was comforting to many people because they were able to see the number of cases actually decrease. The epidemiology of C. diff includes many factors. It is most commonly a nosocomial pathogen, with reservoirs being patients, healthcare workers, and any contaminated hospitals or other environments. Many studies have shown that there is a 20 to 40% rate of colonization in hospitalized adults, but only a 2 to 3% rate of colonization in healthy adults. Other studies have shown that only 28% of C. diff cases are community acquired, and recent studies concluded that these rates could be increasing. Some sources of community include soil, water, pets, meat, and even vegetables. Some of the risks of C. diff include exposure to antibiotics preceding 2 to 3 months, Advanced age, residents in long-term health facilities, and hospitalized patients. There were 4 reported outbreaks of C. diff in the US between 1989 and 1992, and studies showed that 3 hospitals found that patients infected with the epidemic strand of C. diff were significantly more likely to be treated with clindamycin than patients with diarrhea not from the epidemic strand. The epidemic strand is BINAP1027. This strain of C. diff causes the most outbreaks in the world. It's positive for the binary toxin, which contains an 18 base pair deletion in the TCDC gene. It also greatly increases the resistance to fluoroquinolones, which is why it's normally treated with clindamycin. This epidemic strand appears to infect individuals that were not previously considered at risk. These people include young, healthy people and other healthy people in general that are not exposed to any healthcare environment, including antimicrobial therapy. The photo to the right shows the states where the epidemic strand has been present. The transmission of C. diff is rather simple. The bacteria is shed through feces. Contaminated surfaces, devices, and materials such as toilets, bathtubs, and rectal thermometers serve as reservoirs for C. diff. C. diff is also easily transmitted through the hands of healthcare personnel that have came in contact with a contaminated surface. The chart to the right shows the percentage of C. diff cases that were reported within the different departments throughout a hospital. The modes of transmission can either be direct or indirect. It can be hospital acquired, which is considered nosocomial, or community acquired. To acquire it communally, one must ingest C. diff spores from other patients' hands, or even through altered normal intestinal flora from antibiotic therapy, which allows for proliferation of C. diff inside the colon. C. diff has made its way around many parts of the world. It has had emergent strands in North America and Europe for decades, and it has now begun to emerge in Asia. The map to the right shows where C. diff has been found in blue. The mortality rate of C. diff can reach as high as 4.2 to 6.9%. However, mortality rates increase with age, reaching as high as 20% within 30 days of the initial diagnosis. A study found that approximately 29,000 patients died within 30 days of their initial diagnosis, but only 15,000 of those deaths were found to be directly attributable to C. difficile. According to the CDC, Clostridium difficile caused almost 500,000 infections among patients in the United States in a single year.
So the pathology for Clostridium difficile, C. diff is a pathogen that affects the tissues of the intestines. So some symptoms of this include diarrhea, which is the primary symptom and usually the most common and noticeable, as well as frequent bowel movements, stomach pain and cramps, fever, nausea, loss of appetite, and in more serious cases, pseudomembranous colitis, intestinal perforation, and death from secondary sepsis, and that is caused by the intestinal perforations. So the toxins for C. diff. C. diff produces 2 types of toxins, and they're 2 enterotoxins, which are toxin A and toxin B, which are responsible for causing the disease. Toxin A interferes with the cytoskeletons of intestinal epithelial cells and causes neutrophilic infiltration and severe mucosal damage in the intestinal loop assays. The toxins disrupt F-actin microfilaments, which in turn alters the cytoskeleton of the cell. And toxin B is 1,000 times more potent than toxin A. So the damage that this can cause, inflammation of the colon can cause loose pseudomembranes to slough off. If this continues, this can cause perforations in the colon. If the perforations are not treated quickly, then the results may be fatal. Depending on the severity of the damage, some intestinal function could be impaired after recovery, which could be a possible sequelae. So the picture on the left on the top is a picture of a colonoscopy from someone infected with C. diff, and it shows the pseudomembranes that are beginning to slough off. And the diagram on the bottom left shows how C. diff can affect the gut on a cellular level. The time sequence for C. diff. The incubation period is not specifically known, but infection can occur between 48 hours after exposure up to a few months. During the illness, it usually lasts about 2 weeks, but reoccurrence can happen at about 1 to 3 weeks after stopping antibiotics, up to 2 to 3 months later. Decline in convalescence can range depending on the severity of infection, but the period of communicability, which is the time that others can get C. diff, is unknown, but toxins can remain in the stool for weeks. The response and treatment, and antibiotics such as vancomycin or fidaxomicin may be prescribed. If C. diff results from being on an antibiotic, then the patient may be taken off of the medication. But in more serious cases, other treatments may be necessary, but more on that later. The immune response. Toxins cause damage to the colonic epithelium, which increases the permeability of the intestines, which can cause a deeper infection. In response, the immune system releases pro-inflammatory cytokines and chemokines, which recruit immune cells to begin the expression on antimicrobial peptides. Inflammation is important to fighting the infection, but extensive inflammation can be harmful. Further treatment. Surgical procedures to fix perforations or remove sections of the colon may be necessary in severe cases, but a new possible treatment that's on the horizon is fecal microbial transplant, which is currently only available in those with recurrent C. diff. The process is transferring normal fecal bacteria to patients with recurrent C. diff in order to have normal bacteria colonize the colon and prevent further C. diff infections. To prevent getting C. diff from someone who already has it, wash hands thoroughly with soap and water to prevent person-to-person spread, especially after using the bathroom. Using a separate bathroom from individuals with diarrhea or other symptoms, and disinfect surfaces that are frequently touched, as well as washing laundry thoroughly. And healthcare workers should always wear PPEs or personal protective equipment, such as gloves and gowns, when dealing with a patient infected with C. diff.
So as far as economic considerations, as we have already explored, Clostridium difficile infections are most closely associated with healthcare-related incidences. The best way to lower infection rates is by practicing proper sanitization methods in hospitals and clinical settings where Clostridium may be able to proliferate. Clostridium difficile is one of the more easily preventable diseases, and as such, the economy plays relatively less of a part in controlling this disease. The most effective way to limit the spread of the disease is by maintaining proper hygiene in the clinic and in healthcare settings. Classes and proper education should become a routine in these settings, and the cost to be spent in the initial prevention of the disease is relatively low. Implementing policies and practices such as the wearing of gloves and gowns is very important for protection of oneself from bodily fluid secretions and excretions, how one could acquire C. diff infection. Education of medical personnel, sanitization workers, and visitors is essential to controlling any infectious disease, but particularly such a disease as Clostridium difficile. As such, monetary allowances must be made for qualified instructors to offer education on sanitization, particularly with a disease such as Clostridium, and implementing further practices to eradicate spore-forming bacterium. Thanks for watching our presentation.